Good morning, everybody.
Morning.
Good morning.
Good morning.
I don't know who that was. Who was that?
Good morning,
Who was that?
Kristen.
Oh, okay.
Hi.
I can't put everybody up on the screen. Anyway, I got a lot to tell you before we even start. You're going to see a little redundancy. I'm sorry about that. I was going to update, but I couldn't. Ran out of time. You know, I really don't have time to update other than in between semesters, and that goes real fast. So you'll see some redundancy. I'll try to catch it while I'm talking. Today we're talking about mood disorders, and you have a lot of pages that go along with mood disorders. You have a section in Pearson that talks about postpartum depression. For testing purposes, you just need to know a little bit about postpartum depression. Most of it I give you. However, when we look at the test questions, it's not a lot for all this content. So you need to pick and choose those pages that you feel are applicable to this lecture. But there are a lot of pages, both in Pearson and in Halter. Let's go ahead and let's see. Why am I having problems going down? Okay. All right, let's look at the student learning outcomes. Now, I want you to really focus on these SLO sheets and pull out that information in the pages that's on the SLO sheet. What is really important for this content. And really, it's how to take care of someone who is depressed, safety considerations, suicide assessment, bipolar disorder, and dysthymia and cyclothymia. But we have variations of mood disorders throughout life. But I want you to focus in on that. I don't have a lot of questions based on the voluminous amount of pages that are available in the textbook. I just wanted you to be aware of that. It's nice to know, but pick out the stuff you think you need to know. The first, learning outcome. Describe clinical manifestations associated with affective disorders using appropriate terminology. I would look at that mental status form and see what parts of the mental status really apply to someone who has mood disorders. Mood and affect is one, but cognition is one. General appearance is another one. So number two, distinguish between maladaptive grief and depression. You have a section in the book I'm going to hold you responsible for, but it's complicated grief. And, you know, when people are not able to process information regarding the losses that they have, it can get to a point where it really affects their life and taking care of their family and working and things like that. And so we're looking at a person at that point who is having grief, maybe because of unresolved losses. So that's all I really want to say, is that usually grief is, you know, it's a process, and people, however long it will take them, a couple of weeks, a couple of months or whatever, but hopefully we see them coming back to a normal pattern, normal lifestyle, knowing that they'll always remember the grief, but hopefully they'll look at the positive aspects of the person they lost or the circumstances of loss. 3, identify psychological and behavioral cues that may indicate suicidality in at-risk populations. One of the things I saw in your readings was that men and especially elderly men really don't get the services that they need to help them with especially depression. We know that an elderly male is going through many, many losses, and men may not, discussing their feelings and issues that they're dealing with uh, may not be as um, may affect them as far as their body image and the socialization and even the beliefs, the values that people might have, that men are supposed to be strong and things like that. So we need to kind of key into our men. And if any male students have anything to add to that, please unmute yourself so we can bring that up. Describe the collaborative and nursing interventions associated with the care of patients with the mood or affective is the same, very similar terminology, disorder. I have a nursing care plan on the Canvas site that looks at the similarities between a depressed state and a manic state and the differences too. I think I have it under nutrition, communication, self-care, those kind of things. So please look at that. Like I said, I have a whole bunch of resources out there in addition to the 2 books. Staggering statistics. The median age usually is women. However, I question whether or not we have underreporting of men. Median age is 32. That's middle life. Co-occurring anxiety and substance use disorders. Also, we may have eating disorders. That's a co-occurring, or schizophrenia, or chronic medical conditions. We need to think about those people that are dealing with stroke, these ongoing, continuing losses. And I'm sorry I'm losing my voice. I don't know why. And it's one of the leading causes of disability in the United States, ages 15 to 44. Let's go to the next slide. We talked about women. Nearly half have other mental health disorders, and up to 15% of clinically depressed individuals commit suicide. Another interesting fact is that when they look at suicides, they went back and they saw that many of these patients were seen by a healthcare provider. Sorry. All right. Now, we have a whole laundry list of DSM-5 psychiatric disorders. We have major depressive disorder or major depressive episode. Dysthymia is a chronic, low-level type of depression. These people may be working. These people may still be sad. They may not be productive in work. They may have issues with relationships with their spouse. Postpartum depression is something. We have postpartum blues. They think it's hormonal. We think a lot of these disorders are related to the neurotransmitters, and we need to key into what neurotransmitter is going to help this patient out as much as possible. Now, with postpartum depression, a lot of the OBGYN doctors are the ones that are prescribing the antidepressant. We also have premenstrual dysphoric disorder. Starting in the middle of a cycle, people start getting depressed, irritable, they may eat more, they may be short, they may have problems concentrating, and then once they have their period, on an average day 28, then all of a sudden those thoughts and feelings and how they behave change back to a normal state until day 14 or about. All of a sudden the cycle starts again. And that's why a lot of our OBGYN doctors have people on antidepressants. We're coming out of seasonal affective disorder. It has to do with the seasons. People have depressed thoughts and feelings around October, November. It really depends upon the climate, where you live. And how we treat that is through a light therapy, and the patients can do that on their own, sit under a special type of light, and their mood does improve. Just think about the patients that live in the very high northern hemisphere, Alaska, for instance, when the day and nights really do change, and those individuals have problems. But like I said, March, April, May, all of a sudden, it's like we are reborn, kind of, that you feel much better, you're outside, you're more active. Uh, Bipolar disorder, if you know about what depression looks like, the manic phase of bipolar disorder is when these patients are hypoactive, that they don't have any issue with testing reality. However, if it gets a little bit further out, irritable mania, then they can have some big time problems, get themselves in trouble. They forget, they don't think they have a problem. They don't think they need their lithium or their mood stabilizer. And what ends up happening, they may also have issues with alcohol and drugs, and it usually gets them in the hospital. I noticed at River Oaks, our adult psych unit has a lot of patients that have underlying mood disorders. Also, the patients in the substance use unit also have issues with mood disorders. Okay, cyclothymia is like dysthymia. It's low chronic levels of depression and hypomania. So it's a fluctuation in mood, highs and lows, but not as high as a true patient with bipolar disorder. And then I just brought up about substance-induced disorder. All right, so we have this range of mood issues. What is the normal balanced mood? Can anybody tell me?
Euthymia.
Euthymia, right. So you see euthymia, cyclothymia, dysthymia. It's all related to mood disorders, but euthymia is a normal, stable mood. I think with the mental status and doing a practice one at least, that moods is an emotional state. And I have a listing of feelings further down in the lecture. And you can use this to help your patients kind of label how they feel. So we talked about euthymia. Dysphoria is a very depressed mood, sad mood. Mania and hypomania. Affect is how they express what they feeling. And so those terms would be congruent, incongruent, labile. Labile would be someone who is in a manic state. All right, so major depression, the signs and symptoms. The biggie signs and symptoms is the first one, depressed mood, pervasive sadness, and irritability. The second one, that's really a biggie, is thoughts of death, suicide, or has a plan. Those are the big ones. The other signs and symptoms are very vague, and they may be unlooked, by other people, family, and even healthcare providers. And it's nice to see that on admission for any patient in a hospital, they usually have a quick little tool that assesses someone's mood and affect and looks to see if there's a high risk for suicide. Look at these very vague things. Anhedonia, lack of interest in their life, social withdrawal. They start to focus in more on themselves. They worry more. They look at things negatively, their life negatively. Also, difficulty concentrating and feeling overwhelmed. I think I addressed the negative thinking, they feeling helpless and hopeless. These people start thinking that the best thing, the only solution they can come up with to get themselves out of their state is to actually the plausibility of committing suicide, that will end whatever issues that are going on with the patient. And hopefully we get these people before they actually commit suicide. Decreased energy or psychomotor retardation, low self-esteem and confidence. These are the people when you talk to them and say, you really have a nice outfit on today. This thing is so old. I bought it at Walmart, whatever. It's always, whenever you try to give a compliment, they negate it. Physiological weight changes. They may gain weight because they eat more, lack of exercise, or they may lose weight. Sleeping problems. They may have problems going to sleep, staying asleep, or getting up too early. And so they're exhausted. Aches and pains, yes, a lot of these antidepressants are given to people who are dealing with chronic pain. And we already talked about their appetite. Risky behaviors, think of the adolescent. Now, your book talks about age groups. They talk about teenagers and they talk about the elderly. Breeze over that, but be aware that there's an increased risk in the teenage population. There's a lot of things going on with this group, whether they being bullied or they just have strange growth spurts, or if they change their friends and the clothing they wear is different. We need to be on guard. So if you're a school nurse, you need to hone in on that. And also use the peers to help them, because even in like little groups, they can realize they're not alone, that this is a process that a lot of teenagers go through. So with the teenage, self-harm, drinking, drug use, reckless driving, and just being around people that are not their friends and they don't have their best interest at heart. All right, so when we are assessing a patient for depression, we got to rule out if it's a medical problem. Now, granted, yes, they are depressed because of rheumatoid arthritis or because of chronic pain or those kind, or bereavement. Loss is a big thing. When I did some work with individuals in a mood disorders group, they would say that how they got into this situation was because there were so many things happen in their life that they couldn't deal with, and that eventually, with all the losses and with all the changes in their life, and you could see they could probably lose their job as a result of, they're not productive, that can lead into someone really contemplating or having suicidal ideations. All right, I just put this in here because, we're dealing with stigma, and a lot of these actors and performers and things, of that nature are coming out and saying, yeah, I have a bout, and yeah, I had to do this, and I had to be hospitalized and stuff. So it's getting to be more normal, if that's the word to use, but it's out there. And, the more we know, the more we can understand, and the more we can help other people. We already talked about comorbidity, other than with medications. There are some medications that can also cause mood disorders. Risk factors for depression: a prior major depressive episode, a family history, if we think it's hormonal, think it's related to neurotransmitters, especially serotonin, but all of them, all the neurotransmitters can be affected. And that's how we treat people, is that we want to get, we want to kind of tie in the neurotransmitter with the symptoms we see to try to improve the patient's condition. A history of suicide: being female, greater than 40 years of age, that's middle-aged. And what I see happening is that is that sandwich group, women as caregivers, taking care of younger children, taking care of elderly parents, taking care of work, taking care of managing their lives, taking care of issues related to COVID. Let's pull that in. I can see our nurses and our healthcare providers having issues. When it says female, I think the men are underreported. So, with females, we'll tell anybody what's going on with ourselves, right? And help me out, men. With men, a lot of times they are not that emotive, meaning, they get out and talk to people, other than maybe their close friends. When I've asked male students in the past, I ask them, I say, who do you talk to about stressors that are going on in your life? And one gentleman said he used to go over by his dad's house and have coffee with him every morning and just talk about the things that are going on. Both of them were able to share. Another gentleman said, when I go out fishing with my good friend, eventually when we get out there and we're just talking, sometimes I can share information with the other person. So, postpartum period, women are more prone, and women are more prone starting when they start beginning having their periods. So we see that women at that age group are twice as likely to come down with depression as opposed to men. And that's how we're trying to make the link. Also, there's issues related to someone's period that we have postpartum depression and premenstrual dysphoric disorder. We talked about medical illness, lack of social support. With COVID and everything, a lot of people are staying close to home, and they may not be able to reach out to other people. Maybe Zoom. We've done a lot of Zoom things related to patients that were dying in the hospital, and that the nurses are trying to connect the loved ones with their dying relatives. But because of COVID, it is limited possible the social support, the support of others, the lack of contact, lack of intimacy, those issues, negative stressful life events, and alcohol. All right, this is just a visual of what we see in a depression assessment. And yes, it can get to the point where they're suicidal. We're going to talk about suicide a little bit. Now, we're not going to do this as a group. Usually we would do that if we were in class. But I'm strongly suggesting that you look at that mental status form and look at those areas that would be affected with mood disorders in general. Treatment treatment, drug therapy. The big one is the SSRIs, serotonin selective reuptake inhibitors, that is focused on serotonin. But as we get more and more research on depression and mood disorders, we're getting receptor specific, and we use in combinations, maybe serotonin and dopamine, or serotonin and norepinephrine. So the more specific we can get, the least of the side effects we'll see, and a rapid resolution of their mood status. We also have atypical antidepressants, which I'm really trying to talk about, is that we're getting receptor specific. The tricyclists, a lot of times we can't use those in the elderly population because of the serious cardiac issues with that. And the MAOIs, to be honest, I've only taken care of one teenager who was on an MAOI, monoamine oxidase inhibitor. It inhibits the function of monoamine oxidase. And the problem with the MAOIs is that you have to have dietary restrictions, nothing aged, no cheese, usually no fast food, no Chinese food. I know I couldn't be on that medication. And while that teenager was in the hospital, they also changed her out of, she was very compliant, but they did change her medication. Psychotherapy. I've talked a little bit about cognitive behavioral therapy. If we can change any part of someone's, what they think about themselves, how they feel about themselves, and the behavior associated with this faulty thinking and moods that they have, then hopefully we can improve. And a lot of that has to do with looking at their the negativity, or get them to a point of a more realistic view of themselves and the world, and looking at relationships. Exercise. I know a lot of y'all know that, if you're feeling a little stressed out, you get out, run, go, get on your bikes or whatever, helps you with the release of endorphins, and that's great. It can help especially with dysthymia, remember, mild, low-level, chronic type of depression. ECT, electroconvulsive therapy. We rarely see that, but if that is something, especially worked well in our elderly population, the doctor may go ahead and say, yeah, let's go get another 6 to 12 ECT treatments, usually done in an outpatient facility, could be in the hospital, and they give what was in one video 40 watt, like the amount of 40 watts that would light up a light bulb. And they give them medicine to dry up secretions so that they are sedated before they do shock treatment, and it's to the head. Usually patients have a recovery. They may be a little confused in the beginning. However, they do get better and go home. However, I heard of horror stories, and we used to show a video where this woman lost all her memory, lost the reason why she fell in love with her husband, didn't remember anything about any of the pregnancies for any of the children, didn't have any memory of the children growing up. I think that would be really sad. But yes, ECT is a like a surgical consent surgical procedure. And it's not like One Flew Over the Cuckoo's Nest where he's jumping off the bed and things like that. The medications sedate them. And a good treatment might be just a tonic, and a clonic type of response. Okay. All right. How antidepressants work. The newer drugs, you may see changes physiologically with someone who is on like an SSRI, but to have total improvement, usually 4 to 6 weeks after they start. And really, the doctors are tweaking. They slowly building up the medication. They may give all the medication at night. If it's a sedating type of antidepressant, then they're going to give it at night so it'll help them sleep. If it's not working, they may add something. Now, I also see patients, doctors using antipsychotics in addition to antidepressants for some people who do not get the relief that they need. And antidepressants can stop working if they're on a long-term basis. But usually, they're going to keep someone on it for at least 6 months to a year. They may stay on if you believe that that biological theory there that we're missing that neurotransmitter. They may all be on it for life. Okay, they can have holidays, but they really need to, slowly wean off drugs, and they need to let their doctor know and, find out, if they're pregnant or they may have some contraindications there. Antidepressants. What we're going to see when we know that the antidepressant is working is that they're going to be more involved in their self-care. They're going to be more interested in, bathing, wearing clean clothes, participating in group, doing activities, maybe contacting loved ones. However, those feelings of sadness and anhedonia, those psychosocial type things are still there. And what we think is that the reason why they didn't necessarily commit to suicide because they didn't have the energy to do it. However, once we give the antidepressant, their moods are going to be lifted, and that is a critical period where we need to monitor to make sure that they get the support they need. Because if they're suicidal and they got the energy, they might carry it out. And the unfortunate thing is that usually our patients are being discharged before, right when we see them improving physiologically, but not psychologically, which is unfortunate. And they need to know resources. They need to know what support they have that's going to be there if they feel suicidal, who they can talk to. And they also need to know any crisis line that they can contact. Okay. Side effects with dealing with the medication. We have issues with nausea and vomiting, may have sexual issues. Sometimes we need to let them know if there's any kind of issue regarding relations that they need to let the doctor know. And, in some very small cases, there's something called priapism and a sustained erection because of some of these antidepressants. And men need to know. They need to go to the emergency room immediately. Okay. With the MAOIs, you need to, with any of the antidepressants, some of the bodybuilding and the herbal type of products you might get at the health food store may have serotonergic properties. And if they do, they may end up with something called serotonin syndrome, which vital signs are very off, similar to neuroleptic malignant syndrome that we see with the antipsychotics. And how we treat that is symptomatic, changes in vital signs. And we already talked about not stopping any medicines abruptly. This is just an example of cognitive behavioral therapy we've already talked about. And I have a citation in Halter, which is the small care plan book, about some of the cognitive distortions people might have, such as, I'm worthless. We kind of, chip away at that as far as therapy and we try to let the patient look at themselves in a more realistic way, not a fatalistic way. Sample thoughts that you might hear from someone depressed. How's my time? I guess my time's okay. I'm not good enough. No one likes me. He shouldn't treat me that way. The future holds nothing for me. Man, that's a relation, therapeutic communication. If you hear something like that, oh, well, tell me about that. You can't do anything right. Can't do anything right. I'm useless. I fail at everything I do. My partner needs to change for me to be happy. Oh, isn't that an interesting one? I know I'm going to get fired. So if they know they're going to get fired, they probably are going to get fired because of how they working and how they feeling and reacting in the work setting. All right, here's some sample feelings. And, students don't even know how they feel. Let's see, how do I feel this morning? I don't know. Does anybody see an adjective that addresses how they feel? I bet you a lot of y'all feel overwhelmed.
I was just going to say that, overwhelmed.
I was just about to say
Overwhelmed,
that too.
yeah. I
I
think
do.
that might be me too. Overwhelmed. Everything's coming to a head, right? Tense, scared, dread, edgy,
Anxious.
anxious. Yes. Afraid. So it's all under that frightened. Okay. Well, here's there's also a form that they may give out patients. It's got little feeling faces, like happy faces and sad faces and stuff, that we can give patients to help them identify exactly how they feel. All right, ECT, we got a consent. There's some contraindications. There's something new, like in the last 5 to 10 years, repetitive transcranial magnetic stimulation. It's a non-invasive electromagnetic device that delivers a pulse sensation to the cerebral cortex. I have a YouTube site for you. You can do this at home. You can buy the equipment. I think it's rather expensive, or you could come in and get it done. Treatment for 5 days a week for 4 to 6 weeks. That's a lot. But they seem to think that these magnets are helping people. And I've heard that in one situation, it is helping an individual. Suicide. More women try, more men succeed. Why more men succeed? They usually choose many more lethal methods, and usually what they choose is something that you can't intervene with, like a gunshot wound. Fewer than 20% leave notes. However, they may say things or give away things that might be a clue. Suicide, risk factors, being impulsive, it's a fleeting thought. And hopefully, like one patient told me that she just, she was laying in bed. She wanted to kill herself. She thought she had the gun next to her and the bullets, and she just prayed and prayed and prayed. She fell asleep. She woke up the next day, and she felt much better. There was a gentleman that talked about a gun, that he had a gun, but he couldn't find it. I guess his thinking was so disorganized that he couldn't realize that the gun was right next to him, loaded. Firearms in the home, I know that that's a big thing, that they're asking if there's firearms, if they are, to try to have them locked up. We're losing a lot of young kids with accidental gunshots. On antidepressants, other diseases, professional people. That's interesting. And sometimes they can use whatever, this is years ago at Charity Hospital. I heard a story of an anesthesiologist started in a nectine drip with him, which, just bottomed out his breathing. And that's the way he died. And hanging, you know, uh, taking in everybody's pills in the house, jumping off a bridge. There are a lot of things. What we need to consider that when someone says that, their life is worthless, we need to directly ask that question. It's not that we're going to put that thought in their thoughts about, actually killing themselves, but we need to be direct. Have you ever thought of hurting yourself or committing suicide? Yes. Then your questioning gets to be more specific. When? And then you ask, how would you do it? And if there is a high risk for them to actually do it, then the precautions go up, the safety issues go up, especially if they in a facility. Whether they sign a no suicide contract, I don't know if that would really help someone. But if they start thinking about their young children and maybe how others are feeling, maybe things could turn around. But I always tell them, thank you for sharing that with me. We're going to make sure that you stay safe. Some of the things we're going to do will help with that, So giving clues we talked about. Yeah, X the question. Anybody has questions so far? I'm giving you a little time. There is a section of suicide in Pearson and also in the Halter book. Treatment for mental disorders, prevention. Get people early, get them in, get them seen. 70% of elderly suicide victims have seen a professional 1 month before their suicide. I brought that up earlier. Here's a visual on depression. Here's the sad person scale down at the bottom left. And you see, based on the mental status, you see how it affects psychomotor, cognition, mood, socialization, whether they're having thoughts, delusions, hallucinations. Okay. So now we're gonna, what a depressed person looks like. Now we're gonna look at what a manic person looks like. All right. Years ago, they used to call depression unipolar because you just had that depressed state. With bipolar, you have periods of depression and mania. You also have a rapid cycling type of manic episodes that they go through the highs and lows very quickly, hours, days. Marked shifts in mood between depression and mania. Tends to be chronic and recurrent. Sometimes it's undiagnosed for years because they may not see that depressed phase in that individual, or they may not see that manic phase in that individual. But when they do see it, then they realize that it's not a depressed state. I mean, yes, it is, but the true diagnosis would be bipolar disorder. Patty Duke, I know probably don't remember him, you're so young, but Patty Duke had issues with mood, and she also drank. That they kept on treating her for depression. Alcohol is a depressant. But then they saw that manic phase, and that's when she said she was being misdiagnosed all that time. 1% of the population usually is highly educated people, higher income individuals, very creative individuals. Men have more bouts of mania and women depression. There's 2 different types. You don't need to know that for testing purposes. Oh, here's our lady that is the life of the party, the manic behaviors. I'm going fast, intrusive, irritable. They may say things before they even think before saying, and they can be condescending of other people. They don't need to sleep. They got so much to do and they don't need to eat. And you'll see that a lot of times they can't sit to actually eat a meal. So we give things on the run. You may see them pacing a lot. You may see their mind is just going, 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 and they just forget to do things, forget to bathe themselves, change their clothes. They may be inappropriate as far as sexuality and being inappropriate with healthcare providers, and that's including nurses too. Flamboyant. I remember my patient who, when I was in school, she was very manic. She plastered makeup all over, and they have a tendency of wearing loud jewelry and loud clothing. Little attention span, very hard to get information from them when you're trying to do an assessment, and you might need to wait until a little later on once they maybe start their medicines again. And they may be psychotic. Here's a visual of Yvonne, and and we're comparing that manic state with the depressed state. Just another visual that you can use for study purposes. Here's another one of a manic attack. Yes, they're very grandiose. They have a lot of flight ideas. They got to keep on talking because they got to get everything out. Employers love them because they can do all kind of work, but they can get a little bit further out there and their world becomes very chaotic, and they may impulsively go ahead and try to commit suicide, try to hurt someone else. Hypomania is that chronic low-level periods of depression and hypomania. These people probably could work. They're very talkative, very social. They can be the life of the party. Salespeople could be, hypomania would fit well with a salesman, wouldn't it? Because, they're on, with other people. Medications, mood stabilizers such as the anticonvulsants, and I have a listing there: Depakote, Tegretol, Lamictal, and Neurontin. Lithium is a cheap salt. All of these drugs need drug levels to make sure they're within normal limits. Lithium, personally, I don't see a lot of that in our community because, if people sweat more, if they're out, their job maintains that they need to work outside, that they can get lithium toxic very quick because the lithium will replace the sodium ions in the body. The mood stabilizers, if someone's not compliant when they come in and do a drug level, then these drugs are going to be lower than within normal limits. They could use anxiolytics, Klonopin and Ativan. This all is on the nursing care plan handout that I have on Canvas for you. As far as communication, depressed, they're not going to want to talk to you. They're not going to have eye contact. They're just going to be sitting there or standing there. So we need to have frequent interactions with them. We need to constantly assess mood and affect. We need to be supportive, encouraging, and act on any legitimate complaints. They may focus on somatic issues, and so we need to check those out. And always, nursing is to try to instill hope. Look for those activities where the patient has improved, and go and tell them, I noticed that, we didn't have to remind you to take a shower and put new clothes, clean clothes on. That's great. That's showing that you're improving, Manic, we're going to have to redirect them. Big thing about group activity. whether they stay in group, whether someone sits next to them and constantly reminds them, be quiet. We're focusing on on whatever the focus of group is. And we try to decrease environmental stimulation. If you see they getting hyperactive, maybe they shouldn't be in that day room. Maybe it's time to turn that TV off or have more soothing music. Sometimes there's a serenity room or a quiet room where a patient can go to try to decrease their feelings, their impulses, to get more in balance. And if they're doing it by themselves, they asking to get in that room, that's great. You can reinforce that with them. Nutrition, activity, self-care, elimination, discharge planning. That is all under the nursing care plan that I have for you. Discharge planning, whether they're manic or extremely depressed, they can be suicidal. One being impulsivity and that they can't think through things. Depression also, they can't process, that tomorrow will be a better day. Who is going to be there for them once they're discharged? The support groups, the community resources, and family know. Living with someone who's depressed can be extremely draining on the rest of the family. They may have to take over. I know this one gentleman in group, he talked about when he's manic, his oldest son would go ahead and assume the male parental role of that family. And he says, once, I had treatment, I'm on my medicines, I'm doing much better. Sometimes it's hard for that adult child to give up that responsibility. And so, I have issues with him because now I'm normal again, I'm stable and I can do this. And so I could see some family discord, with someone who's manic. Here's a bunch of resources for you. And that's it. If you have any questions, I will stay on. I will go ahead and take the recording, stop the recording, but I will stay on.
Thank you, Professor Hoppy.
Okay.
Yeah, thank you, Dr.
Y'all have a good break.
Thank you, Dr. Hoppy.
Thank you.